Thank you, Michelina. I just want to say that was wonderful questions at the end of the last talk. It really gets down to why we're here. We're here because we want to meet all of you. We're looking particularly to make more connections in the ion channel field. We're looking for collaborators. We're looking for technology to license. Come find us, come talk with us. What I'm going to present here today is really what's going on, the state of things in clinical medicine with these neurodegenerative disorders. And in case you haven't heard, it's a revolution. There is new concepts, new modes of approaching treatment, and it's needed because for the last 20, 30 years, we have not made any progress. So the problem, Dr. Jernstein outlined it very well. You have these disorders that particularly affect the aging population, and it is a big problem. It presents a tremendous cost to society, taking care of these people, treating these people, and as Dr. Jernstein mentioned, there is no cure, there is no effective treatment, there is no disease-modifying treatment. We have essentially nothing that we can really offer that makes a substantial difference. So I've been treating people with Alzheimer's disease for 20 years now, and I'm looking back on 20 years of doing that and of being able to offer them that has no more of an effect, essentially, than a cup of coffee. That's the current state of the medicines that we use today. So what's needed? Where the field has gone is to precision medicine. We're looking at doing a better job of identifying the risk factors on an individual basis, looking at multiple risk factors for what's actually driving the disease in that person, and come up with a tailored approach to therapy. And we think that the answer is not going to be one drug or one treatment, but is going to be a combination of a number of things to really impact this disease and make a meaningful difference. This reflects a situation, a change in approach to Alzheimer's that's going on at a global level and at a national level. The World Health Organization has recently identified this as one of the challenges that they want all of the countries in the developed world with aging populations to address in a meaningful way. What Dr. Jernstein showed, and that you could take away from his presentation, is that the pathology, particularly of Alzheimer's disease, and that's what I'm going to focus on because of the brief time here today, is very complicated and complex. You have contributions from accumulation of beta amyloid protein, you have contributions from abnormally phosphorylated tau protein, you have microglial activation, you have inflammation, you have ion channels in all of this. This is what the amyloid plaque looks like in the brain in the top slide. It surrounds the neurons. It's toxic to the neurons. It probably is killing the neurons through the calcium influx that Oleg described. The bottom picture shows the abnormally accumulated tau protein, the neurofibrillary tangle. It's also toxic to the neurons. The interesting thing about this is that both of these pathologies, while they are interconnected and feed on each other, they start at different times in the disease process, separated by many years, even a decade, and they spread through the brain in completely different ways. That's what these two pictures here are showing. The amyloid protein first appears in the neocortex and then gradually spreads through the brain, where the neurofibrillary tangles first start in the locus coeruleus, transentorhinal cortex, and then go to the amygdala, and finally to the neocortex. So they spread throughout the brain in totally different ways. The interesting thing about these is that they've been shown to spread through a prion-type mechanism, where the beta amyloid oligomers will then bind to other beta amyloid proteins and cause further polymerization. This can spread from cell to cell, from neuron to neuron. Same thing for the abnormally phosphorylated tau. And there's now evidence of human-to-human transmission, where patients in the United Kingdom who received pituitary extracts in the early 1980s developed pathologic changes of Alzheimer's disease decades earlier when they were in their 30s and 40s, before it should have been should have been seen, showing that you can have actual human-to-human documented transmission of the amyloid protein and the phosphorylated tau protein and cause Alzheimer's pathology in people who otherwise would not have it. And this is, of course, what it does to the brain. Once these things progress for too long, you get degeneration, you get pronounced atrophy, you get loss of brain tissue, and of course, this severely damages how people think, impacts their ability to function. We can look for some of these changes right now where people are still alive. This is an FDG PET scan that shows metabolism in the brain. We can look at changes for how the brain is functioning and diagnose people as being at higher risk, and I'd separate out Alzheimer's disease from frontotemporal disease. We can also now image the amyloid protein accumulation in people's brains while they're still living. This is a relatively new development that's being applied now in clinical practice. And we hope to be able to image the phosphorylated tau accumulation in the neurofibrillary tangles in the near future as well. As Dr. Jernstein mentioned, the failures in development of therapeutics for Alzheimer's disease go on and on and on. Over 400 compounds targeting amyloid accumulation. Many compounds already that targeted tau accumulation have also failed. There have been compounds that target synaptic preservation, reducing inflammation, oxidative stress. Nothing has shown to make a meaningful benefit, any kind of a disease-modifying effect. The medications that we currently have are purely symptomatic, and as I mentioned, they're about as effective as drinking a cup of coffee. What's needed is going to be something more than just a single medication. It's going to be an entire lifestyle approach, a precision medicine approach, targeting multiple risk factors as well as new medications, things that haven't been tried yet before. We need to expand what's being looked at, we need to expand the pipeline, and we need to get beyond just amyloid and tau. When you look at precision medicine, this is being applied all around the world. There's a recent study out of Finland that just showed an effect with reducing cognitive decline in patients with Alzheimer's disease by targeting risk factors. This is a recent study that was just published out of the Cleveland Clinic and was done partially in Singapore, where they looked at if you just target all of the known risk factors for the disease, everything that you can target. You throw the whole, everything, including the kitchen sink at these people. It's not a sniper rifle, it's a shotgun. And you do everything that you can. Over the course of just 9 months on average, they were able to decrease progression in about 80% of people with Alzheimer's disease, which is something that hasn't been shown before. Which gets us excited. That this isn't a field where we're not going to have an answer. This isn't a field where we're not going to, be able to make a significant impact. It can be done, but it's going to take a lot of work, and it's not going to be just one medication targeting one thing. Okay, so essentially, that's pretty much all I wanted to say today about that. These are just some shots of the campus to contrast with the shots of the traffic. And I'm actually going to close it at that. And we've got some time for questions if anybody has any questions. Yeah. As I mentioned, that's why we're here. We are investing in drug discovery. We're actively licensing things, and that's one of the reasons that I wanted to be out here today and get a chance to meet you all and have you meet me. In terms of ion channels, right? There's a number of things that we think could be looked at. New technologies could be developed. If you were going to target something, I would look, at what Dr. Jernstein had shown, that these amyloid proteins and tau proteins form calcium ion channels. Obviously, a large calcium influx into a neuron is pretty disastrous, for it. A new therapeutic targeting that type of a mechanism would be very novel. It would be something that could be added on to any of the other therapies that are out there being developed. Sodium channels, I think, are one that are very much overlooked, and there's opportunity there as well.
Just a question, what about timing? Because what I remember about Alzheimer's disease is that sometimes even in clinical trial, what we are testing is not working because it's not at the right time, or the Alzheimer's is too advanced, and at that point you cannot recover what has been lost. But it's just that if you can find something or some marker that you thought, okay, you will develop in 5-10 years Alzheimer's, probably this drug will work. What are your thoughts?
Yeah, no, absolutely. That's a great question. So the question essentially is the timing on therapeutics. If you wait until the horse is out of the barn and you've had all this neurodegeneration, you've had this loss of tissue, this loss of neurons, you're not likely to recover from it. That's part of why the neuroimaging slides that I showed, why the neuroimaging is so important. With the neuroimaging, you can identify people at the pre-symptomatic stage who are accumulating beta amyloid, and in the near future, we hope to be able to identify people that are accumulating the tau protein accumulations as well with the neuroimaging while they're still alive and pre-symptomatic. Yes, I agree with you completely. If you're gonna prevent this, if you're going to stop people from suffering through this, you need to treat them early. You need to treat them before they've lost, a lot of the cognition and everything else. And the only way to do that is risk factor stratification, some of these neuroimaging techniques, and try to identify people early on. The neat thing is that the precision medicine studies, the ones coming out of Cleveland Clinic, the ones coming out of Del Bredesen, the ones coming out of Singapore, is that they've shown that even later on, even people where Alzheimer's disease is diagnosed already, you can make a difference. You can at least prevent progression. And this is done right now through nothing more than risk factor modification. So if we have some therapeutics that actually are disease modifying, I wouldn't give up even on the people who have been diagnosed already. Yes, sir.
Could you expand, you mentioned sodium channels as obviously potential. Could you expand on that a little bit?
Yeah, so there's a couple of ways that sodium channels, can make an impact on the disease. One of those is through epileptic potentials. So a fair number of patients, about 20 to 30% with Alzheimer's disease, will either have epileptic activity. So if I was looking at sodium channels, I'd be looking at Na1.2 and Na1.6 in particular. And I'd be looking at it in terms of either seizure prevention or impacting these subclinical epileptiform activity that occurs in up to a third of patients with Alzheimer's.
Aaron, question right here.
Yeah, Chris.
Thanks so much for being here. There's a parallel with heart failure, where once you get heart failure, the damage is done, it's too late to cure it. So the medical community developed biomarkers like blood pressure, cholesterol, to reduce the risk of heart failure. And I know that's a big push in Alzheimer's research. Do you have any thoughts on what those biomarkers could be? Something that you could get everyone to think about to lower the risk of Alzheimer's?
Yeah, no, absolutely. So in terms of biomarkers, they lump them into three categories. So you have biomarkers that look at amyloid accumulation, biomarkers that look at tau accumulation and neurofibrillary tangles, and biomarkers of neurodegeneration. Some of these biomarkers that are currently available out there are the imaging studies. You can have a radioactive labeled compound and a PET scan. You can image the amyloid accumulation occurring in people with Alzheimer's disease. There's compounds in the works that will allow tau imaging as well. Right now, they're not specific enough for use commercially. The other way you can get at it with biomarkers for Alzheimer's disease is the spinal fluid. You can measure the levels of amyloid protein and tau protein in the spinal fluid. The amyloid protein, when it accumulates in the brain, the concentration in the spinal fluid lessens. The tau protein gets released when the neurons degenerate. The levels of tau protein go up in the spinal fluid. The ratio between the two gets even more sensitive and specific. Right now, those are the biomarkers. The other one is volumetric MRI scans, looking at the volumes of structures in the brain like the hippocampus, and looking for signs of neuronal degeneration from that.
What do you think about regenerative medicine approaches, such as like inducing neurogenesis, let's say in situ, to replace lost neurons?
Yeah, it's exciting. There's so much out there on the horizon that is going to be really exciting in terms of approaches that right now are almost science fiction rather than real science. But regeneration, stem cells, computer-brain interface, electronic enhancements to memory, and things of that nature. It's a very exciting time to be in because you can look ahead and look around the corner, and see what it might be like several decades in the future, and it's really exciting. Okay, well, thank you all very much. It's very nice to meet you all.